One of the challenges, I think, in thinking about an asset-based approach to health is that it's counterintuitive. It seems to me, and you'll forgive this observation, I'll try and narrow it to everywhere else in the world except the UK, but it seems to me that an awful lot of professional interventions around health as they relate to citizens look like that, where what we're trying to do is come up with really good products that we can bring to industrial scale to give to patients, clients, or customers. Which is sort of like what McDonald's does with burger, chips, that kind of stuff. And I don't think it works, because it seems to me that health is not a product. It's not something you can commodify, and it's not something you can produce or consume. Does that make sense to you? That's why the lights are on. You can't. It's a condition. And at best, you can co-produce it with citizens and with professionals working together. But I don't believe, I have never ever seen an example of where a system has been able to unilaterally produce somebody's health. Have you? Take that as a no. So what we want to try to do is think maybe a little bit differently about what we mean by health and who are the producers of health. And it seems to me that there's certain things that institutions can do and do very, very well when it comes to health, but they're also deeply, deeply limited. There's things they simply cannot do. But the good news is they have partners. And I suppose earlier on we were hearing about business as a potential partner, and that's fine. I also think there's a third leg to the stool, and that's communities, citizens. And I think, in fact, that they are probably the most potentially important partners of the NHS. And I know that you have a long and rich history of working in partnership with citizens, but I want to suggest to you we can go further and we can do more. One of the things that often strikes me is when it comes to citizen engagement, sometimes I think people think about it as motherhood and apple pie. It's a nice thing to do if you have time, but in terms of actually expecting citizens and communities to produce solid outcomes when it comes to health, a lot of the professionals that I've worked with around the world aren't really convinced. They tend to be of the view that the really good stuff, the impactful stuff, comes in the form of services and programs. But the idea that citizens, through mutuality and relatedness and connectedness, can actually produce some of their own health outcomes is not one that I think is commonly held. I think that's changing a little bit. Recently, I was at a conference, not too far away from here, where somebody said, it was a CEO of an organization, said that citizens are like a box of chocolates. They're sweet, but there's far too many nuts to be dealing with. What's interesting is I think we've shifted over time from the handmade and homemade version of healthcare, where we had to find ways of using our resources as citizens and as communities to produce all kinds of health outcomes. That's shifted over the last 80 or so years. I sometimes joke, shift happens, but in the process of shift happening, sometimes we lose some very, very important things. Now, it's true to say that 80-odd years ago, there were things happening in communities that were deeply unjust, deeply worrying, and at a whole range of different levels in terms of social justice, not stuff we want to go back to. But there was always a sense as well that there were good things that were happening. Children were connected in a way that they don't appear to me to be connected into the center of community life. Older people had an experience of aging well, which is very different than the experience they have now. And I suppose I want to put to you that it may be time, not so much to go back to the way things were 80 years ago, but to at least ring-fence that good stuff and make sure that we're intentional about, if it isn't in place now, about trying to catalyze a situation where it can be put in place. I suppose one of the things that I would argue with is that community isn't just a box of chocolates that's sweet with a lot of nuts. It's a place with deep, deep, rich capacity. And I think one of the difficulties is when we start thinking about people as patients, or as clients, or as consumers, we're setting up a power dynamic where we're the fixers and they're broken. And that's fine if that's what you want to do, But if what you want to do is mobilize citizen empowerment, if you want to be genuine about co-production, then I think we need to shift beyond thinking about people as consumers of our services and products. Because there's so much more to life than services, and there's so much more at stake than money. There are things that communities and citizens can do that no matter how well-resourced, no matter how capable, no matter how competent a system, whether it's a marketplace intervention or it's a public state intervention, no matter how well-resourced it is, there are certain things that only citizens can do. And indeed, it's fair to say that there's certain things that systems can never do. So let me just go through some of what they are. Let me put this out of my hand, first of all. I think some of the things that only people, all of us included, because we wear two hats. I think, we spend some of our time being paid to do professional jobs, but we're also primarily citizens. I think one of the main things that citizens can do that systems can't is they can care. And what I mean by care, and I want to reclaim this word back into the citizen space and out of the professional space. What I mean by care is the freely given gift of the heart, one person to another. You can't pay me to care for you. You can't mandate me to care for you. You can't manage the care I give you because it's in a citizen space. It's in civic space, and you can't dictate it. Institutions have tried. Great states of oppression have tried. So we have examples in our history. Nazi Germany was an example of what happens when a country dominates its citizens with great institutions. The trains ran on time, but nobody cared. So care is the freely given gift of the heart, one person to another. Systems can't produce it, and it can't be consumed. That's something that can only happen in families and in neighborhoods and among friends. But it's also interesting. 80% of all innovation that was mentioned earlier on comes from the edge. It comes from the fringes. Well, most people, and you can think about this in terms of your own life experience, most people source their employment through their social networks, through people they know. Often we have this notion that people open a paper and find the job, and then, or go to a local employment service and are connected to a job. 80% or more, I would think, find their jobs through social connections. That cannot be produced. We can't create that. We can't prototype and substitute that through services or institutions or programs. So that's kind of vital. Care of the environment. Again and again we see, particularly when it comes to being able to respond to emergency, and we're seeing examples of that in Australia and in Japan and so on, tragic examples of that. But again and again, if you want proof that you absolutely need a powerful civic space where citizens care and they're prepared to engage and they care not just about each other but their environment, those tragedies show the importance of that. And so often they mobilize people to do things that maybe typically they don't tend to do. So care of environment, it's down at the end of the day to each of us, how we recycle, how we actually behave, how we connect with each other. But we're here to talk over these 2 days about health. So let me just say a word or two about health, because it seems to me, and I don't want to put a percentage on this because I know there's epidemiologists in the room and I'm not an epidemiologist, but it seems to me that there are 5 key determinants of health. I think the first is personal behavior. The second is social networks, how connected we are to family, friends, and people in a reciprocal relationship, not in a relationship that's based on charity, on fixing us, on, as Frank said earlier on, doing to us, but a reciprocal relationship, a related experience. I think the others are related to our environmental status, our environmental conditions, and our economic conditions. Way down at the bottom of the pile is access to health care. So I don't know, I've heard different epidemiologists take a punt on this, and I'm not an authority on it, but I've heard, a growing consensus in the different parts of the world I've spoken, where epidemiologists seem to be saying that about 75% of what determines our health is within communities, or what I would call community assets. Now, we have a joke that we tell in Ireland, and the joke is, Father Ted. You know Father Ted? Dennis, you might know Father Ted. Father Ted is Actually, it's an English program, which is a skit on an Irish priest, okay? Or a set of Irish priests who live on an island called Craggy Island, I think, is it? Anyway, as the story goes, Father Ted, you see, is standing outside his house one evening under a street lamp like these lamps, and he's looking for something. He's patting his trousers, and he's clearly lost something. And Mary passes by, and Mary says, Father, how are you? And Father says, I'm not well, Mary. And Mary says, well, what's wrong with you, Father? And Father says, I'm after losing something, Mary. And she says, what did you lose? He said, I lost me feckin' keys, Father Ted. And she says, did you, Father? And he says, I did. And she says, where'd you lose them, Father? He says, I'm after losing them up under the bed, Mary. And she stops and she says, what are you doing out here looking for them, Father? She says, I can't see what I'm doing under the bed, Mary. At least there's light here. I'm fully convinced that most healthcare interventions, if they're coming from the professional space, and their focus is primarily on trying to create an institutional response to healthcare issues, they're like Father Ted. They're looking for the solution in the well-lit places, but the solution's actually under the bed. In the kind of the murky, darker kind of areas that we're not so familiar with, that motherhood and apple pie space, the chocolates, it's actually in communities. So communities aren't just places where people live and where they sleep. They're places where the production of health potentially and actually is at its greatest. So it's interesting, if we step beyond the debate about austerity and we actually just start thinking about how we might, as practitioners, support health to be liberated, I think a good place to start is to look for the keys under the bed. What I think all this means is that for a long time, and there's reasons I'll go into for this, but for a long time, it seems to me that what we've been trying to do is we've been trying to, as donors and as partners and as government, and I include the third sector in some instances in this, not to be critical, but just to make an observation. I think what we've been trying to do is serve citizens by coming up with services that we feel are useful to them. And while that's really, really important, the difficulty is the starting point. And I want to suggest to you that the starting point needs to be a citizen-led, a citizen-driven starting point. So I want to put it to you that some of the way we engage with citizens is perverse. It gives us what we call an iatrogenic outcome, the opposite of what we intend. And I don't want to put that to you as a criticism of what you do. I want to put it forward as a critique which will give us hope for the future. Is that okay? My grandmother, who's since passed away, she grew up and raised her kids, my mother and uncles and aunts, in a community called Balnacurra Weston. And she was one of the great community organizers. And when kids would come and bemoan the fact that they couldn't get an interview or a job because of their address, she would say to them, remember this, no matter how rich you are, you have needs. And no matter how poor you are, you have gifts. So even though these people may think that you come from nothing, you're the same as them. And that's stayed with me all my life. I think there's a lot of wisdom in that. One of the things that interests me most when I think about the invitation to be in a relationship between an institution and a citizen is that so often institutions start with an engagement that's around people's needs, around their pathologies, around what they don't have. And the difficulty with that, even though it's very well intentioned, is that's the half-empty part of the glass. So what we spend a lot of time, we talked about this in the master class earlier on. The master didn't turn up, but it was a good class. But we talked about it in the master class, and we talked about this idea that when you engage with people like that, what you're doing is you're amassing an inventory of their misery. Tell me everything that's wrong and broken and pathological and dysfunctional about you, which implies that somehow I'm going to figure out how to fix it. That kind of power dynamic, I think, has really dogged healthcare systems around the world and has led to a situation where we have treated citizens not as citizens, but as clients of our services. The word client comes from a Greek derivative which means to be on one's back and powerless. You couldn't make this up. This is true. So either subconsciously we're saying what we mean, or it's a major boo-boo. I want to think about it. So if what we want to do is engage citizens as co-producers, as equal partners in creating a good life, then I think it's important that we actually start thinking about the way we engage, the very first sequence of engagement. If we're engaging with people based on needs analysis, then can I put it to you that the first thing we need to do, I believe, is analyze what we mean by needs. In other words, I suggest to you that needs analysis is what needs analysis. Imagine this. When I start with people, I say, tell me what you're missing and tell me what you don't have. What does that do to the dynamic? It puts me in the position of authority. It puts me in the role of power. It puts me in the narrative is very simple. You will be better because I know better, because I'm the professional. Doctor knows best. Well, actually, all of the evidence suggests otherwise. And that's no negative, it's not a casting an aspersion on a doctor or a professional. It's simply recognizing that professionals can't do our push-ups for us. They can't do our living for us. And they can't do our dying for us either. So if needs analysis is putting people that we want to be partners with in the role of clients, then I think we need to stop doing needs analysis. And we need to find a different way of engaging with people. My proposal is that we start by thinking not around their needs, but start by engaging them around their assets and their strengths. Not so that we can ignore people's needs, but so that we can begin an engagement that says, we want to work with what you have and what we have to address your needs in partnership. And I think it's really important to be very, very intentional about that narrative. And if we're thinking about an integrated approach, it would be really interesting to look at what would happen if every agency, third sector and public sector, and indeed the marketplace, decided, well, let's all of us intentionally just do that for starters. Let's all of us intentionally engage in sequential terms, first with people's assets, and then together with them, their needs. I believe, and I've seen it all over the world, I believe that's a game changer, right there. Because what you're actually saying now, as Frank pointed out earlier on, is you and the people that you live with and that you share community with, you are key primary investors in your own health. And our job is to support you, not to fix you. I'm not knocking needs. I really want to emphasize this. But what I think has happened is that we've started to confuse, in the professional world, we've started to confuse needs with our service categories. So we've started to think about people and their needs very much on the basis of what we have in our kit bag to address those needs. And so many of those needs are framed within the context of service categories like homelessness, which go so far, but not far enough when it comes to actually producing outcomes that I would describe as good life outcomes. I recently had a conversation with an aunt who was told she had 6 months to live. And I got into deep trouble with my family when I asked her what a good life would look like for those next 6 months. I was told I was uncaring, and I was this, and I was that, and I was the other. It was much, much more caring to ask her what services she wanted as she faced into her death. And I don't buy that. I think that's absolutely perverse. But maybe that's just me. What I want to say in relation to needs is I think there are 4 fundamental needs. And I want to frame this, if you like, within the context of thinking about helping, because all of us as professionals, I think, share something in common. I think we share the desire to be helpful and to help those that we serve. And I think that can, it can sometimes be hard to express, but I always believe it's at the heart of every professional that I've ever encountered in any country that I've worked in. But it's really interesting for me because one of the things that I would put to you is if you take this proposition that there are 4 basic needs that we all have, regardless of our economic status or where we live, or indeed our health. We all need to belong at some level, to be connected, because we're social beings. I think we all need some kind of a sense of competence in our lives, some kind of sense that we have agency and we can affect change. And I also believe that we need a sense of autonomy. You know, we shouldn't have to give up our independence and our autonomy to receive support and care. And finally, we need to feel secure, economically and emotionally. So I guess my question to the NHS and to you folks here is, how can you ensure that your endeavors to help people don't undermine those 4 fundamental needs? Because often what I'm seeing is interventions and programs that leave people feeling incompetent, like you're trying to fix them. I'm seeing programs and interventions that take people's autonomy. And I'm seeing programs and interventions that don't make people more secure. They institutionalize them. They build a bridge between them and the center of our services, programs, and institutions, rather than the center of a warm, hospitable community. And I'm not saying this again to be critical of your work. I'm just trying to be provocative. And I think there is a difference. But recently I visited some folks who are involved in working with some rather large hospitals in the UK, and they were telling me about bed clogging, is that what you call it, or bed blocking? Yeah, it's different expressions in different countries. And it was interesting because they were saying, you know, that something like 1 in every 5 people over the age of 65 are blocking beds in the UK. And I was asking them what they thought might be a solution to that. And so they were giving me different propositions. But all of the propositions, it struck me anyway, that all of the propositions were around institutional ideas. So it was more beds or, you know, step-down care or whatever it was. And I thought, that's really, really interesting, because that's kind of like a Father Ted moment for me. Because you see, the issue isn't the absence of a hospital bed there, is it? The issue there is the absence of a hospitable community.